Good morning to everybody. It is a pleasure for me to start this session on newborn care by presenting on two topics. The updates on neonatal resuscitation guidelines and the home visits for a newborn survival. The presentation is divided in three main parts. First, the update on the basic, the guidelines on basic neonatal resuscitation, then an update on the evidence for the home visits, and then a bit of reporting on the meeting on the policy and practices for home visits that was done in Geneva this year. So by starting on the neonatal resuscitation guidelines, you know, as many of you probably know, we had the pink guidelines on neonatal resuscitation that were published in 1998, and they are focusing on the basic resuscitation, which means resuscitation with bag and mask. And this is these guidelines have been revised this year. As all the guidelines of WHO, we follow the process that was described also for the previous guideline in the previous days. But basically, the principles are to develop the guidelines on systematic review of all the available evidence, develop recommendations that are clear with the evidence stated, spelled out clearly, and we use the grade system in order to systematize and grading the evidence. The strength of the recommendation is based on the balance of benefits, harms, but also on other characteristics like values and preference, and also the cost. And finally, the guidelines take in consideration all the range of circumstances in which they are supposed to be implemented. Now, going to the recommendation of and the update of the resuscitation guidelines. So the main recommendation is that in a newly born term or preterm babies of less of more than 32 gestational weeks, requiring positive pressure ventilation, ventilation should be initiated with air. This recommendation is a strong recommendation and is based on quality evidence of moderate quality of evidence on an effect on mortality. Now, the previous guidelines were not we are also recommending air, but not so clearly, and we didn't have the same the same level of evidence to support the recommendation. Now, more evidence is available compared to the previous time on the importance, on the advantage of starting with air instead of oxygen. Now, the guidelines also have review the procedures for resuscitating the baby. So what is new in these guidelines is more evidence again supporting late cord clamping. So we don't have to rush to cut the cord. The first step in the resuscitation, in the care of the baby actually, in the essential neonatal care, remains drying the baby, not cutting the cord. So we start with drying the baby, then cord can be clamped at least after 1 minute, and we don't need to rush. And regarding additional stimulation after drying, no need to be too active. This should be limited to rubbing the back 2-3 times before cutting the cord and starting the positive pressure ventilation. There is evidence, again, supporting the use of not routine suctioning. This was also already mentioned in the previous guideline, but now evidence again is consolidating this. So suction should be limited only to 2 situations. The first one is when there is meconium stained amniotic fluid, and the baby is not breathing. So, and the second situation is there is clear amniotic fluid and the baby is not breathing and the mouth or nose are full of secretion, preventing effective ventilation. So we can be less interventionist in the routine section and suctioning. And many of you who provide care to newborns or training on essential newborn care may witness how often babies are exposed to routine suctioning without this being recommended intervention for all. Now, regarding the way of providing positive pressure ventilation, as before, as in the previous guidelines, the initiation of the ventilation should be done within 1 minute after birth if the baby is not able to breathe on his own. And as I said, ventilation should be initiated with the air and given using by a self-inflating bag and face mask. So this should be available, the equipment should be available in all health facilities who are managing newborns. The assessment of the successful ventilation should be done by measuring heart rate and observing the movement of the chest. And priority should be given to to the ventilation over chest compression. Regarding stopping ventilation, the guidelines recommend, of course, these guidelines are done for facilities where you are not expected to have the competencies and equipment to provide advanced resuscitation. So if no spontaneous breathing appears, the resuscitation should be stopped. It can be stopped after 10 minutes of effective positive pressure ventilation if no detectable heart rate, and after 20 minutes if the heart rate continues to be below 60 beats per minute. And this is, in the previous guidelines, we were using longer time to decide, but there is sufficient evidence to make this recommendation because of the complication of asphyxia, basically, continue with the situation of asphyxia. Now, moving on the second part of the presentation, which is on the home visits. As you know, there has been released in 2009 a joint statement between UNICEF and WHO on the home visits, and since then countries have started to implement them as a strategy to improve survival of the newborn babies. And this statement was based on the evidence, on the systematic review, which has been published in the bulletin of the World Health Organization in 2010, which was summarizing the results of 5 studies. So these 5 studies, I'm sorry, I don't know how much you can see, but the pooled results of the 5 studies indicate that the home visits can provide a reduction of 38% reduction in neonatal mortality. 4 of the studies, as you can see in the slides, were at a good confidence interval, and the other, one of the studies was not significant, but there is the summary of the results of these studies show an important reduction on neonatal mortality by this intervention. Then after that, other 3 studies have been published, you can see there, and since 2009, so a new, this is a summary of the studies. So by pooling the results of these studies, we have now a 21% reduction in neonatal mortalities. And this is the reason why there is a difference is due to the type of studies, but also due to the type of context in which the studies were conducted. In any case, is an important reduction of neonatal mortality, as you can see, overall. And why this, there is a variability of impact on the home visits? As I said, it depends on the study size and the type of study. In fact, smaller efficacy studies were showing a much larger mortality impact than the effectiveness studies, as you can see, so 40% versus 12%, but still important. Another point to be made is that studies which are conducted in countries, in settings with higher neonatal mortality rate have show our highest impact in, with the home visits, as well as studies conducted in setting where there is a large proportion of home visits. Another important point of this to be made is that the home visits have an effect also on other newborn care practices, and this is an example of early initiation of breastfeeding. Here is basically all the studies show that the home visit increase the proportion of women being able to start breastfeeding early in the first hour after birth. And this is an important result in terms of, because breastfeeding is also a life-saving, a life survival intervention, a survival intervention. Then, so the summary of the evidence, what can we say? Home visit in combination with the community promotion of healthy practice reduce neonatal mortality rate by 21%. This impact is likely to be larger in setting with high neonatal mortality, and when most of the births occurs at home, and all studies show improvements in newborn care practice. And important from India, there is also an effect beyond the neonatal period. And then the last few slides are on the informal consultation, on the on policy and practice on neonatal visits, home visits. It was an assessment done, a survey done on 47 countries, and we saw that 27, so a large majority, 60% of countries surveyed had policy on home visits. All these visits were tackling the mother and the baby, and most of the country also included the home visits in pregnancy, in antenatal care. And then in terms of implementation, the countries, some countries, only 2 countries have not yet started to implement, but 6 countries are already scaling up at 1/3 of coverage. 6 countries have reached more than 1/3 coverage, and a large majority, 15 countries, have already moved to national coverage. Regarding the timing of the postnatal visits, just I know I have only 1 minute, but most of the countries are able to do either 3 home recommended visits. In any case, the visits are done within the first week of life. But it's important to say that all countries are able to do 2, 3, or 3 visits before 1 week, which is the time when most of the deaths are taking place. Now, on the content of the home visit, again, this includes care for the promotion of appropriate care, but also the information on the danger signs and on family support. As you can see, all of these countries are doing this. While treatment is not important and provided. And then human resources, so, as you can see from the slides very quickly, several kinds of providers can do home visits in the countries that were served, from volunteers with and without incentives to community care workers, or even nurse, midwives, and so on. There were some difficulties. I mean, by assessing the challenges, let's say the easiest to put in place is the policy. A bit less difficult to do the guidelines and the training, and a bit more challenging is to maintain, to support, to maintain motivation and to support the program, and also to continue to support the health system component, supplies and monitoring, supervision, and so on. So finally, so this is the last slides, the consultation on the home visit, the group recommended to continue to advocate for increased adoption on postnatal policies and increased resources for their implementation. WHO should define an optimal package of interventions for the mother and baby at the same time and provide estimates for their costs. And then partners should develop an implementation guide and define also the indicators for tracking progress. And also some research priorities were identified, particularly in how to link the work of the community care workers with the health facilities, models for implementing this approach in different settings, and the use of technologies to support the implementation. And with this, I'm finished on these two important intervention, basic resuscitation and home visit for neonatal survival. Thank you.